Okay, this will be a quick review of the aggressive and non-aggressive imaging features of mandibular lesions, and I'll show a case example. This expands upon a concept I discussed in a previous lecture on medication-related osteonecrosis, but in summary, the mandible and maxilla, it can look weird on imaging, and it can look varied and still be normal. Or even if abnormal, it still could be benign, even with a weird looking appearance. It can be lucent in some patients or sclerotic in some patients, and it doesn't necessarily mean that it's something you need to worry about. So here are two funny looking mandibular lesions. You can see that there's bilateral areas of sclerotic bone along the lingual cortices of the anterior mandible. Now, this is kind of an ant mini. You just see it and you know what it is. These are mandibular tori. They're exostoses, so it's just proliferation of cortical bone. And you can get this in the palate, the midline palate, and it's called a palatal torus. And when you get them bilaterally on the lingual aspects of the mandible, usually adjacent to the mandibular premolars, this is called mandibular tori, or you may hear it as torus mandibularis. This is completely benign. They are not tumors, and they don't need to be treated. Now, the one time they may need to be treated is if the patient loses his or her teeth and they need to put a denture on the lower dental arch. These bony protuberances get in the way, and you can't possibly make a denture to fit over it. So an oral surgeon will just kind of chip away these exostoses so that a denture can be made, but otherwise they don't require treatment. So the previous slide demonstrated a case of non-aggressive mandibular lesions. So I just want to review the imaging findings that would make you think that a lesion is aggressive. And it can be bone without soft tissue coverage, which is essentially exposed bone, either in the oral cavity or extraorally. This usually is more of a clinical diagnosis than an imaging diagnosis. A sequestra is usually a spicual bone that is detached from the mandible. A periosteal reaction, this is more of a soft call. You can have periosteal reactions in non-aggressive processes, but it could also be seen in an aggressive process. Cortical expansion is a sign of an aggressive lesion, but it still doesn't mean it's a malignant lesion. There's a number of odontogenic cysts that will cause cortical expansion, but are not malignant. Cortical erosion, on the other hand, is definitely more of an aggressive feature. There's no cyst or completely benign entity that would cause cortical erosion. Now, it doesn't necessarily mean it's neoplastic. Infectious causes can cause erosion as well. Overlying soft tissue stranding, again, very nonspecific. It essentially just means inflammation, but it's not a completely benign finding either. And then a ground glass appearance, that's nonspecific in some sense, but classically that ground glass appearance is associated with fibrous dysplasia. And I would classify fibrous dysplasia as a fairly aggressive lesion because it does get worse and it can cause significant mass effect on adjacent structures. So here's the same patient I showed you before that had the bilateral mandibular tori, and here he is 2 years later. Now, this patient developed a squamous cell carcinoma of the head and neck and showed up, had a soft tissue neck CT, had perineural invasion and skull base involvement, but it was also noted that he had erosive changes of the right anterior hemimandible. So you can see right where his mandibular torus used to be, you have this eroded appearance with what looks like sequestra, pieces of bone that are not attached to the rest of the mandible. This is unequivocally an aggressive process. Now, when you see this type of erosion and aggressive features, again, it's still nonspecific, but it does imply an aggressive process. So could this be metastatic disease from the patient's squamous cell cancer? Yes. Could it be osteomyelitis? Yes. If the patient received radiation to the head and neck, this could be radiation-induced osteonecrosis. If the patient was on bisphosphonates, this could be bisphosphonate-related osteonecrosis. So this is not specific, but certainly is aggressive. And I would say, given the patient's history, is certainly suspicious for metastatic disease of squamous cell carcinoma. Here's a quick review. Non-aggressive lesions will not demonstrate cortical erosion, overlying soft tissue changes, exposed bone without soft tissue covering, periosteal reaction, cortical expansion. Now, you may say, hey, wait a minute, this cortex looks expanded. I would argue that this lesion is cortically based, but is not expanding the cortex. Lesions that are in the marrow that subsequently expand the cortex could be aggressive. But this lesion is cortically based, and for the most part, cortically based lesions are less aggressive than a marrow-based lesion, and that makes sense. Metastatic disease tends to go to the marrow, infection tends to affect the marrow. Again, that is not a hard and fast rule. There is an entity called juxtacortical or perosteal osteosarcoma, which actually is a less aggressive form of osteosarcoma, but nevertheless is an aggressive lesion. So although this looks funny, this is a known entity. It's an ant mini. These are bilateral mandibular tori. They are do not touch lesions unless the patient needs a denture. Contrast this with the same patient 2 years later, where we have clear erosive changes and sequestra formation. This is definitely aggressive, but also nonspecific, and this would require tissue biopsy. This could be radiation-induced osteonecrosis. This could be bisphosphonate-related osteonecrosis. This could be osteomyelitis. This could be tumor. So there you go. That's a summary of some aggressive versus non-aggressive imaging features of lesions in the mandible.